SimLearn Central Line Insertion Training Program, brought to you by Mercy. Hello, I am Dr. Jeffrey H. Barsick, Associate Professor of Medicine in the Division of Hospital Medicine at Northwestern University Feinberg School of Medicine. I also serve as Director of Simulation and Patient Safety for Graduate Medical Education. Today, we will be discussing central venous catheters. Specifically, we will cover indications, contraindications, the procedure, and associated complications of central venous catheter insertion. This module will focus on indications and contraindications. Indications for central venous catheters include hemodynamic monitoring, pacing, administration of medications that might induce thrombophlebitis, hemodialysis, plasmapheresis, or lack of peripheral access. When placing a pulmonary artery catheter for hemodynamic monitoring or a temporary pacing wire, the right internal jugular vein is the insertion site of choice because of its direct path from the superior vena cava to the right atrium. However, if the right internal jugular is not available, the second choice for insertion is the left subclavian vein. Additionally, treatments such as total parenteral nutrition, 3% saline, hydrochloric acid, and some chemotherapeutics can induce thrombophlebitis if instilled in a peripheral vein. And please remember that if you cannot get a peripheral IV, it is reasonable to put in a central line in patients that require access. However, depending on the patient's presentation, it might be appropriate to make aggressive attempts at putting in a peripheral catheter or even, in an emergency situation, placing an intraosseous line. By itself, volume resuscitation is not an adequate indication for placing a central venous catheter. However, with the need for early goal-directed therapy in patients with septic shock, central venous oxygen saturation and central venous pressure monitoring may be indicated and require a central line. Remember Poiseuille's law? The rate of flow through a tube is proportional to the length and diameter of that tube. Therefore, 2 large-bore peripheral IVs may be the best option for rapid volume infusion. Contraindications to central venous catheter insertion include coagulopathy, thrombocytopenia, and bleeding. There are no clear published guidelines for PT-INR or PTT cutoffs, or for that matter, even platelet cutoffs for safe line insertion. However, avoid the subclavian site with coagulopathy or thrombocytopenia because these vessels cannot be compressed externally. Please consider the risks and benefits of inserting a central venous catheter if a patient has low platelets or coagulopathy. For instance, if a patient is on Coumadin and has an INR of 2.5 and there is not adequate time to give fresh frozen plasma, it is deemed reasonably safe to go ahead and place an internal jugular line with ultrasound guidance. Venous thrombosis, skin infection, or breakdown at the site of entry are also contraindications to placing a line. In a patient with end-stage renal disease or in a patient that is going to be on dialysis in the future, avoid the subclavian vein due to the fact that these patients tend to get stenosis of this site. Additionally, it is a good idea to avoid the subclavian site in patients that have been in the hospital multiple times with multiple lines because they can also get stenosis. During cardiopulmonary resuscitation, it is difficult to put in an internal jugular or subclavian vein catheter because chest compressions are ongoing. With the new guidelines emphasizing the need for adequate chest compressions, it may be inappropriate to put an internal jugular or subclavian line in these patients. On the other hand, the American Heart Association does not recommend the use of femoral lines during advanced cardiac life support due to their overall complications. Previously, there were concerns about the ability of lines located below the diaphragm to deliver adequate drugs during CPR. However, evidence suggests that peripheral IVs deliver drugs to the heart at a similar rate to central lines if an adequate bolus is given in flush. Therefore, the American Heart Association recommends a peripheral IV or intraosseous access to administer cardiac arrest drugs. Finally, upper extremity central lines should be placed on the same side as a damaged lung. For instance, if your patient has pneumonia, please place the line on the same side as the pneumonia. Now let's talk about a real patient. The patient was a 64-year-old male who was admitted with cellulitis and bacteremia with group G streptococcus. He was on antibiotics and was recovering. Then, on hospital day 3, he came back from radiology and the nurse could not measure a blood pressure. Carotid pulses were not palpable and the patient's skin became mottled. A cardiac arrest was called. The responding code team placed a right femoral central line because it was the easiest line to access during ongoing intubation and chest compressions. Cardiac resuscitation medications were given through a peripheral IV for treatment of pulseless electrical activity. Unfortunately, the patient expired. The autopsy demonstrated a lesion on the mitral valve that was not detected by echocardiography. Additionally, the autopsy showed a large retroperitoneal hemorrhage, and this was listed as a contributing factor to his death. There are several take-home messages in this case study. First, clinicians often place femoral lines during cardiac arrest when they are not necessary for resuscitation efforts. Second, placing a line in an emergency situation increases the risk of both mechanical and infectious complications during insertion. And finally, if further intravenous access is needed, an intraosseous line could be inserted much quicker than a central line. In the next module, we will discuss the various approaches to the central venous catheter insertion procedure.